Today I will try to explain the role of AMH in the pathophysiology of the PCOS. We all have observed that in IVF population, when the AMH level is high, we are normally happy because we expect a better response to the stimulation, we expect good number of the eggs, we expect good fertilization, good number of embryos and better pregnancy rate. But the same expectation cannot be kept when the AMH level is high in anovulatory PCOS. So why it happens? What is the role of AMH in the pathogenesis of the PCOS? Why AMH is high? We'll try to understand. Although it is not a fully understood subject, there are certain controversial findings, there are certain missing links, but for proper stimulation and proper understanding the role of AMH, we have to understand. It is now very well established that ovarian hyperthecosis and increased androgen productions are central to the endocrine disturbances in the PCOS. The hyperthecosis and androgenism may be because of the various reasons. Antimullerian hormone is an important regulator, I would say gatekeeper, of folliculogenesis in the ovaries. It is secreted by the granulosa cells of ovarian follicles and its serum levels are elevated 2 to 3 folds in women with PCOS in comparison with the normo-ovulatory woman. Consistent with the increased number of the small antral follicles in PCOS, however, it is unclear whether AMH is simply a marker which is increased in PCOS or actually an important contributing factor to its pathogenesis. The improved understanding of the association between AMH and PCOS may help in finding the way for the development of new therapies for PCOS. The AMH in the female is produced exclusively by ovarian granulosa cells. Its concentration declines with the age and becomes undetectable after menopause. The concentration of this hormone slightly fluctuates during different phases of menstrual cycle, but not significantly enough to affect its measurement. During folliculogenesis, the AMH protein expression begins at the primary follicle stage. The highest expression is detected in FSH dependent preantral and small antral follicle, which are less than 4 mm in diameter. And the AMH expression gradually declines as the follicle is growing and it is absent in the follicle larger than 8 mm. It has been suggested that the why AMH expression becomes less in larger follicle. It is suggested that the role of follicle stimulating hormone and estrogens in downregulation of expression of AMH and its messenger RNA during differentiation of small antral follicle into large antral follicle. The cessation of AMH production from larger antral follicle more than 10 mm is thought to be essential for dominant follicle selection. So it is now clear that the AMH acts as an important inhibitory factor for follicular growth. The data suggest that it is not only the increased number of the follicles with resultant increased granulosa cell mass, but also a greater production by individual granulosa cell, that is the underlying AMH overproduction in the PCOS. Several studies have demonstrated that AMH is correlated with the severity of the PCOS manifestation, including oligomenorrhea, hyperandrogenism, and polycystic ovarian morphology. The how the AMH causes ovulatory dysfunction in the PCOS. It has been suggested that the AMH inhibits folliculogenesis by interference with the concentration and action of FSH in the ovaries. The PCOS can be divided into anovulatory and ovulatory based on serum AMH concentration, as it has been seen that the women with the anovulatory PCOS were found to have 18 times higher AMH concentration than the women with ovulatory PCOS without any overlapping areas. It itself suggests that the role of increased AMH in follicle arrest in PCOS is by inhibiting FSH early in the folliculogenesis. So it implies that the greater AMH concentration would reflect a greater number of AMH producing 2 to 5 millimeter follicles. It has been noted that the 2 to 5 millimeter follicular number was positively correlated with the severity of the menstrual disorder in PCOS, being highest in women with the amenorrhea. The cause of higher production of AMH still remains unknown. But however, it is assumed that the factors which are closely related to PCOS pathophysiology, such as increased LH, androgen levels, and insulin resistance, may be implemented. Several studies have shown that the serum AMH is correlated with the LH and androgen levels. Now, what does the LH does? LH overexpresses the AMH. It helps in the overexpression of the AMH, and AMH induce follicle arrest. Moreover, androgens play a role in stimulating early FSH dependent stage of follicular growth, and which again produces more AMH and thus contributes to the increased AMH production. It has been found a positive correlation between AMH and fasting insulin level in women with and without PCOS. The insulin may increase AMH due to increased androgen production and presence, increased androgen production, thereby the increased recruitment of the follicle, smaller follicle, and thereby increases the AMH production. So for the PCOS, there is increased production of androgen, which cause increase in the AMH level. There is elevated LH level, which also elevates the AMH. Elevated insulin again increases the AMH level. The increased AMH level does two things. One, it decreases the FSH sensitivity of the follicle, so there is a follicle arrest and an ovulation. And another thing it does, it decreases the aromatase expression. So conversion of androgen to estrogen doesn't happen. So there is increased androgen production, which in turn elevates the AMH level. Now let us understand how AMH is measurement is important in infertility cases. It has been shown that the AMH concentration can be used as a predictor of menstrual response after weight loss in overweight and obese women with PCOS. The Moran et al. Studied the effect of weight loss treatment on the regulation of menstrual cycle in PCOS and found that lower baseline AMH concentration in responders in comparison to non-responder, suggesting the use of pre-treatment AMH as an important clinical predictor of the response to the weight loss in PCOS. So, in any obese PCOS woman, if the basal AMH level is less, there are bright chances of improvising the menstrual regularity and ovulatory cycle after weight loss. However, the weight loss did not result in the decrease in the AMH concentration. It has been found a significant difference in serum AMH concentration between PCOS women who responded to ovulation induction with clomiphene citrate versus those who were non-responder. What is the threshold level? The threshold value of AMH less than 1.2 nanogram was found to predict response to clomiphene citrate in obese women with PCOS. Similarly, in a study of 60 anovulatory women with PCOS who underwent ovulation induction with the clomiphene citrate, the serum AMH concentration at the baseline was found to be predictive of ovulation and pregnancy. The ovulation and pregnancy rate were significantly higher in patients with low AMH, less than 3.4 nanogram, versus the woman with AMH 3.4 nanogram per ml or greater. As I mentioned earlier, the evidence that high AMH concentration are associated with the poor ART outcome in PCOS women may appear to contradict the existing evidence that high AMH is correlated with a good IVF response. In a study, they found a comparable fertilization rate, quantity of good quality embryos, but the lower embryo implantation rate were observed in the high AMH group in comparison to a low and average AMH group. In addition, they found a non-significant trend towards lower clinical pregnancy rate in high AMH group compared with the other group. However, in a different study, Seme et al. Found no significant correlation between AMH concentration and clinical pregnancy rate. How the vitamin D affects the AMH? The supplementation of vitamin D3 in PCOS women who are vitamin D3 deficient has been shown to improve elevated androgen levels, insulin resistance, and menstrual cyclicity. Abnormally elevated AMH concentration in PCOS women were decreased following vitamin D3 administration, suggesting that the AMH may be mechanic- mechanistically linked to vitamin D3 induced beneficial effects in PCOS. What is the relation of AMH level in ovarian drilling? The preoperative serum AMH concentration was shown to predictive of treatment response to LOD as reflected by a significantly greater ovulation rate in women with lower pre-treatment AMH concentration. In their study, the AMH cutoff level they found 7.7 nanogram, which was predictive of ovulation following laparoscopic ovarian drilling with 78% sensitivity and 76% specificity. So, we must remember the cutoff level of 7.7, which can predict the beneficial effect of laparoscopic ovarian drilling. It is possible that the decreased local ovarian production of AMH following laparoscopic ovarian drilling may lead to increased follicular responsiveness to FSH and release from the follicular arrest. So, in conclusion, the AMH plays an inhibitory role in the follicular development and recruitment, contributing to anovulation. It also likely promotes hyperandrogenism and insulin resistance in PCOS. The elevated serum AMH concentration are predictive of poor response to various treatment of PCOS, including weight loss, ovulation induction, and laparoscopic ovarian drilling. While the clinical improvement in various parameters following treatment is associated with the serum AMH decline. The further supporting an important role of AMH in the pathophysiology of this syndrome. The further basic and experimental studies will be paramount in improving our understanding of AMH related pathophysiology of PCOS, and which may lead to a development of new therapy for this poorly understood disorder. Thank you.